This conference will now be recorded.
Assalamu alaikum. Bismillahirrahmanirrahim. This is Dr. OSAMA AKL, MRCOG. Today, inshallah, we will talk about how we can prepare in the best way for the coming exam for MRCOG Part 2, which, inshallah, will be in July 2021. At first, please let me thank all of you who came today. Okay, and I wish, inshallah, it will be a fruitful day. We have at first introduction about MRCOG Part 2, how to prepare. Then we talk about small scientific topic. I choose it today to have an example how we can explain the topics to be more easy in the course, inshallah. Bismillahirrahmanirrahim. At first, you are going, inshallah, to have step number 2 in your way to pass MRCOG exams. So you are going to have MRCOG exam part 2. The exam now is computer based, so it's not done in a hotel anymore. Okay, you go to a center called person view where there are computer sets. Okay, you sit to one of them and have the exam computer based. So it's not a matter of paperwork anymore. It's computer based, which can be more better that there is no need to transfer answers from the question sheet to the answer sheet. It's already computerized. Just you take the answer. And don't worry, they gave you a pen and paper so you can document anything in a paper. You can solve, if you need, for example, to solve a statistical question, you can solve it at first on a paper, then you can take the answer on the computer. Okay. So it will be computer-based exam, inshallah. All of you finished already part 1. Some of you already tried to have before MRCOG exam part 2. Between part 1 and part 2, no more than 7 years should pass if you are planning to be a trainee in UK. If you are not planning to be a trainee in UK, maximum 10 years between part 1 and part 2. Any doctor who had part 1 exam and didn't have part 2 exam, whatever the result, pass or fail, but should sit once for the exam within 10 years, part 1 will be cancelled. I mean, this doctor should again sit for part 1 MRCOG exam. So it's not allowed by any way for any doctor who had part 1 that he should not allow 10 years to pass without at least sitting once for MRCOG Part 2 exam. After Part 2, inshallah, comes the rule for Part 3 exam, and there are difficulties in this year in doctors planning to have Part 3 exam because of COVID effect on exam centers. But anyway, we are talking today about Part 2. Okay, the question, Part 2, is it easy? Nobody can say it's easy. Why? Part 2 material, Part 2 curriculum is extendable, is dilatable. You know, knowledge is increasing every day. And in Part 2, our curriculum is every guideline coming from UK related to gynecology and obstetrics. Number 1, green top guidelines, nice guidelines, top articles, British journal articles, and Stratog modules, also Faculty of Sexual and Reproductive Health, PASH guidelines, cancer research guidelines, many data for Part 2 exam. That's why you will need a help. Not only a help from a trainer or a course, even help from your friends, from your colleagues. I always recommend don't go in this way alone. Be in a company. Why? The way is not easy. Don't be alone at all. Okay. Not only that, others can help you. Talking about other study partners, also you can help them. All of you will make the way more and more easy, more and more better for everybody of you. So don't walk in this way alone. It will be difficult if you walk alone in this way. What will be about preparation for the coming exam, which will be in July 2021. It will be in 6th of July. It will be Tuesday. Always part 2 exam on Tuesday and the part 1 always on Monday. It will be 6th of July 2021. It was written and published on the MRCOG website, the date of the coming exam. But centers still not written yet, because according to effect of COVID, some centers may be allowed to work in some countries, and other countries there are precautions or lockdown. Situation actually is not steady in this year. That's why so far the website didn't write in which centers the coming exam will be. 6th of July, inshallah. This is the coming MRCOG part 2 exam. It will be Tuesday, inshallah. Okay, so what will be our package for the coming exam, inshallah? Number 1, online sessions. We will have 40 online sessions. It will be every Tuesday and every Friday. I will tell you in which hour. Okay, there is a slide according to the countries. Every meeting is about 4 to 5 hours, and there is a break in between. So 2 meetings per week. In this meeting, there will be a PowerPoint. I will explain what the guideline said. For example, our topic will be diabetes. So I will talk about diabetes from all UK guidelines, from NICE guideline, from the articles. Okay, so all data related to this topic. So you don't need to search for guidelines. You don't need to open a guideline even. All your study will be from the PowerPoint itself. Talking about 40 meetings, every meeting about 4 to 5 hours. So talking about from 160 to 200 online, 200 hours online meetings. Okay, after the lecture, what if I have work? I didn't attend the lecture. From where I can study? After every lecture, I upload in the same day its PowerPoint and its video on my website, OSAMAAKL.com. Okay, every candidate, every member will have an account on this website, so he can access easily to watch the PowerPoint and watch the video to study until the day of the exam, inshallah. So in your account, you will find the PowerPoint, you will find the videos of the recordings of the meeting, and also you will find quiz. Every topic will have a quiz containing some questions. You will answer them, then you will receive feedback from the site. What is your mark and what was the right answers for every question. So it will be very formative, interactive platform. So you can study and also can solve questions. Also on the website, you will have an exam every 2 weeks. So we can assess what about your studying in the last 2 weeks. So every month there will be 2 exams. These exams talking about specific topics I explained in the last 2 weeks. So you can assess your progress. So you can receive feedback. So you can assess your studying. Okay. Every member will have access to the website containing the material 6 months, which is sufficient to be to the coming exam July 2021. Doctor, what if I will not have my exam in July? Situation is not steady. No problem. You can have extension extra 6 months for small fees until you have the exam. You can refresh this account every 6 months for some fees. Okay. Very important thing. You don't need any other material. As I told you that material for part 2 is very large, very extendable. You don't need to search everywhere. The lecture, inshallah, will be updated until the last night before the lecture. Okay, so you don't need to search for any update. The course language will be in English, same as my courses for part 3, while my courses for part 1 are in Arabic, but part 2 in English. Okay, so what will be the preparation for the coming exam, which will be in 6th of July 2021. So far, we don't know which centers will have the exam. And you know by the new regulations that you don't need to have assessment of training for part 2. Assessment of training now is needed only for part 3. If you did assessment of training once before and you sent it before and was accepted, you don't need to send assessment of training anymore, even for part 3. As long as you made it once and was accepted by the MRCOG, you don't need to make it anymore. Okay, so for part 2, there is no need for assessment of training. So if you pass part 1, your next step to book and pay for part 2 exam without the need for any certificates, any paperwork, not needed. Some doctors asked about English exam, not needed at all, neither for part 1 or 2 or 3 MRCOG. It will be needed later if you want to register in the General Medical Council. But for the exams, no need for any English exam. Okay. The venues, so far we don't know, but it will be computer-based in-person view centers, which is present in many countries over the world. Okay, it will be same like this. Okay, you will be on a computer answering the exam. Okay, booking didn't start yet. Booking usually starts about 4 months before the exam. So booking for the exam will start maybe in March, early April. So you have to start studying from now, and then you will book for the exam. Nobody can wait to start for studying after booking, because after booking you have only 3 months. So you have to start. So you have to put a plan. You have to decide from now. I will have, inshallah, my exam in July. I will start studying from now, inshallah. Okay. The fees for part 2 exam, it's variable among the countries. They classify countries into band A, band B, band C, according to the economic level. So through the website, you will go to know which band your country is. Egypt, for example, is band 2. So doctors in Egypt will pay 493 sterling pounds. Okay, sure, you will pay on the website using a Visa card. Okay. The exam form. The exam is made in part 2 is made of 2 papers. It's computer based, but let's say 2 papers, paper 1 and paper 2. Every paper containing 100 questions. 50 questions called MQ and 50 questions called single best answer. Same for paper 2, 50 MQ and 50 single best answer. Every paper you have 3 hours, so 180 minutes to solve it. Same for paper 2, 3 hours, 180 minutes. The RSOG recommends 110 minutes for MQs and 70 minutes for single best answer. So we say 1 minute for every single best answer and 1 minute for every MQ. What is the difference between single best answer and MQ? Already you know single best answer from part 1, MRCOG. So you have a question and some options, you choose one of them. You choose the best one of them. While in MQs, the format is different. In MQs, he starts by telling you the options. For example, the coming questions will be about a patient with preeclampsia. Please, from every option, choose single best one. Every choice can be chosen once or more than once or not chosen at all. Then he will give you many options Okay, can be 15, 16, 20, even more than 20 options. Then he start question number 1, question number 2, so and so, question number 3, so and so. For every question, you will choose one of the many options. And this is the target of the RCOG, to have EMQ questions. That for every question, you will find there are many options available. So the chance of having the right answer by luck will be reduced. So it will decrease the chance of luck in the exam. So only doctor who studied well can choose which answer of these will be best. We have a technique how to solve these questions. Okay. In between the two papers, you have 1 hour break to relax, not to study, to relax. Okay, to drink coffee, to drink tea, to refresh your mind. Okay, so 2 papers, every paper 100 questions. Half of the questions EMQs, half of the questions single best answer. And actually, 50 EMQs, 50 single best answer. These 50 EMQs, they have 60% of the mark, while single best answer, they have 40% of the mark. So EMQs, they have higher marks, more marks in the exam than single best answers. That's why we try as much as possible to reduce mistakes in the EMQs. Okay, so right answers in EMQs will increase your chance, inshallah, of success. So what was about the previous courses? Okay, I will show some slides which I published before since years until the last year for doctors who passed in my course. Okay, here, for example, course preparing for July 2017 exam. Alhamdulillah, many of doctors who passed the exam, they passed already part 3. Some of them already became instructors for part 1 and 2 and 3 exam. Okay, this was my first course in 2017. Okay, this was the Jan 2018 exam. These doctors passed. This was July 2018 exam from different countries: India, Pakistan, Egypt, Tunisia, Algeria, Iraq, UK, Sudan, Malaysia. It was for Jan 2019 exam. Okay, Jan 2019. Sure, you know some of these doctors. Some of them may be working already with you in your hospital, or you know them through Facebook already. Okay, Egypt. Okay, Bangladesh, Sudan, India, UK, Iraq. Okay, what will be the coming course, inshallah? Okay, we said the components. There are 40 online meetings. There will be exam every 2 weeks. Question bank for every topic and collection of questions. The important questions that may came before in the exam. There will be collection of questions, the important ones, in addition to quiz topic-wise. Full material on the website. You will have 6 months access to study if you miss any lecture, and it will be your only source of studying for the exam. And there is additional option of having the crash course in the last months before the exam. Okay, so full package will include these 6 items. Okay, when we will start, inshallah? Next, or the first meeting in the course will be Tuesday 26th of January, inshallah. Then we meet every Tuesday and Friday, every Tuesday and Friday until half of June, inshallah. At half of June already we will be finishing the long course. Then we will start the crash course in the coming 2 weeks before, 2 or 3 weeks before the exam, inshallah. So before 1st of July, we finished the long course, the 40 meetings, and also we finished the crash course, inshallah. Okay, our timing by Cairo timing. I will show you another slide by country's timing. 2 p.m. So same like now, same like today. 2 p.m. Cairo local time or 12 p.m. GMT. Friday 10 a.m. So more early on Fridays. Okay, this is country-wise. Okay, UK timing, Egypt, Saudi Arabia, Emirates, Pakistan, and India timing. This is the timing by KSA. It's now 3 p.m. in Saudi Arabia, right? It's now 3 p.m. 3.30. Yes. So this is the exact timing. 3.30 p.m. right? So
Yes,
this is the timing.
yes.
Yes. Yes. Thank you. So you can know from here the timing according to your country. Every meeting 4 to 5 hours with a small break in between. This is our curriculum. Okay, these are not all the topics. There are other topics in addition to all this list. Okay, diabetes, phenylketonuria, early pregnancy, including ectopic miscarriage and molar pregnancy and GTD guideline, hypertension, collapse, SCGA small for gestational age, recurrent pregnancy loss, cord prolapse, obstetric cholestasis, thrombocytopenia, anti-RBCs antibodies, cardiac diseases with pregnancy, full day for cardiac disease, preterm labor, psychiatric disorders, neurological disorders including epilepsy and headache, breech, extremocephalic version, nerve injuries, group B streptococci, intrapartum care, instrumental delivery, repair of perineal tear, CTG, intrapartum monitoring, cesarean section, vaginal birth after cesarean section, acute colonic pseudo-obstruction, venous thromboembolism management and prophylaxis, ovarian vein thrombosis, breast cancer, bronchial asthma, appendicitis with pregnancy, twins and multiple pregnancy, skin eruptions, renal disease, liquor problems, amniocentesis, sickle cell disease and thalassemia, antepartum hemorrhage, postpartum hemorrhage, placenta accreta spectrum, postpartum hemorrhage, intrauterine fetal death, abortion care, reduced fetal kicks, induction of labor, abdominal incisions, TOG article summary, antenatal care, teaching thyroid disorders with pregnancy and with fertility, subfertility full day, contraception 2 full scientific days, female genital mutilation, menopause, ovarian cyst in postmenopausal and non-menopausal, infections in gynecology, infections in obstetrics, including viral, bacterial, fungal, everything. Okay, including COVID, including Zika, including all infections, pelvic organ prolapse, laparoscopy, urogyny, including incontinence, including bladder pain syndrome, including how you can apply cystoscopy, endometriosis, irritable bowel disease, inflammatory bowel disease, irritable bowel syndrome. We will talk today about irritable bowel syndrome. It's our small topic today. Endometrial hyperplasia, cancer cervix, and the new cervical screening program, endometrial cancer, obesity, ethics and governance, complex social factors with pregnancy, hysteroscopy, abnormal uterine bleeding, sexual abuse, governance and ethics, we said it, vulval disorders and vulval cancer, ovarian cancer, ergonomics in laparoscopy, sepsis, during pregnancy and the postpartum sepsis, postmenopausal bleeding, thyroid, we said thyroid, and statistics. Okay, So these are some of the topics. There are additional some few topics also added to the course. Okay, in the crash course, we concentrate upon the most important points in the long course, plus some important points must be said before the exam in the crash course. Okay, so from where come these lectures? Okay, from the UK guidelines. Our course is specific for MRCOG and also for MRCPI, for Irish membership, PASH, faculty, BHIVA, ISHRI guidelines. Okay, everything related to these topics coming from UK most recent guidelines. Okay, exam every 2 weeks and the question bank, topic wise and collection and exam questions. This is a website. This is a platform you are going to study with throughout the coming 6 months. Okay, you will register here, so you will have an account. Okay, after having an account, I will tell you what steps you will do so you can have the material on your account here. For example, here in this account having some of these topics as an example. For example, if you open diabetes, okay, you will find the PowerPoint, you will find the videos, and you will find the quiz. After finishing the PowerPoint, after studying the videos, you will press a button complete. So you know that you studied this topic. So you know what percentage of this topic you studied. So you will find, oh my God, I didn't study subfertility before. It's 0%. I will study it. You study and press complete, so you know you studied already this topic. Okay, from here also you can know the result of the quiz you had before. Here all courses you are enrolled in, finished ones, passed ones, failed ones, so you need to study again. Okay, here an example. This is a lecture. You will find its video and PowerPoint. There is the PowerPoint, second PowerPoint. After studying everyone, you press complete. So it will be counted that you studied this topic. Okay, here an example from part 1 course. Okay, this is a PDF, but part 2 all are PowerPoint. Okay, here an example. This is a video. This is a screenshot from one of the videos, but I make it full screen. This is a screenshot from the video from the website. Example for a quiz. Okay, multipars, contracting, poor contractions, but good dilatation, so routine care. You press the button, you press next. After finishing the quiz, you press complete. Okay, here you will find the explanation of the answer. It will appear to you. And you can again retake the exam, retake the quiz again. Here the website will give you a summary. What is your score? How many questions right? How many questions wrong? And you can review so you can see the correction of any mistakes. You will help me to improve this by giving your comments. So below every video, below every PowerPoint, there is a place to put a comment or to ask a question, inshallah. Okay, Dr. Reem, sweep the screen. You will see my screen. Okay, these are some of the comments of doctors who had my previous courses.
Doctor, Assalamu alaikum.
Wa alaikum salam.
Doctor, I am from Pakistan. Dr. Jahara, sorry, I joined just now.
Welcome, doctor. Do you have a question?
I'm asking that how many duration has passed of this class because I joined just now.
Okay, I think about 30 minutes. Don't worry, there is a video recording. I will give it to you.
Okay, so
Okay.
okay, sir. Oh, Hindi.
Okay, these are some of the comments of doctors from previous courses. I will open the door for the questions after few moments. Okay.
Excuse me, can repeat the use of the website and how to answer because
I
it
will
is
show you.
new.
I will show you an example now.
Mm.
Okay, here's the website. So all course members will need to, I will log out to show you how you can register. Okay, from here you need to register to make a new account on the website. Okay, after doing register, then you can do login after making the account. When you log in to the website, you can open your own profile from here on the upper right corner. Open your profile. Then you will find which courses you are already you subscribed. So how to add courses here? You have two methods. Number one, by contacting us. For example, you paid using bank transfer or Western or whatever. Okay, you will send the receipt to the accountant. Then we will add the course to your account. Another method to pay online on the website, but this service is not working yet. It will work within a few days, inshallah, but not working so far. Okay, how much I will say at the end, inshallah. Okay, for example, let's see one of the courses. Let's see, for example, diabetes. Okay. Okay, so here, diabetes PowerPoint, video 1, video 2, video 3, video 4. Let's try the PowerPoint. For example, here you can put review and put comment and ask a question. For example, there is something difficult in a certain slide. You can write a comment. By asking a question, I will reply to your comment within 24 hours, inshallah. Okay, this is a PowerPoint. From here, you can change the slides and you can make it full screen like this. So you can study. Okay. After finishing, I studied this all PowerPoint. I can press here, complete. So it will be counted that I studied this one. Then you can go to next one, for example, to watch the video. Let's see one of the videos. Here you can put a comment or ask a question if something is not clear. Okay, here you can put a comment or ask a question. After studying the video, here you can press complete. Okay, you can make the video full screen. You can also change the speed of the video to be 2x or to be slow, because I know some doctors prefer to study in a speed manner. So you can change the speed from here. Okay, when you press complete, it means that, for example, there are 5 videos. When you press complete for one of them, the website will write to you that you studied 20% of the lecture, but you can study it unlimited number of times, no problem. Okay. For example, this is one of the videos. Here I can change the speed. 1.5x is good. Same like what you do on YouTube. Okay. I watch videos on YouTube, 1.5x, 1.75x. I don't have time to watch the video by 1x. Okay. So this is how PowerPoint and videos you can use them. Okay, after finishing every one, you can press complete. So it will be counted that you studied this one before, but you can study it unlimited number of times. You have 6 months. Okay, I encourage you to study multiple times, not only once. Okay, so congratulations, you finished this video, so it will be counted that you finished it before. Okay. I can receive questions. Somebody has a question?
You will send the link of website on WhatsApp?
Sure. All members.
Yes, okay.
Okay, will be helped to have an account. Look here, it's now I finished 20% of diabetes. But don't press complete without studying, huh? Only press complete when you study the PowerPoint or the video. Okay. Yes. Any other question?
Yes, doctor, how much are the fees for getting access to the material for another 6 months?
Okay, the website is very new. You will be the first group to have the studying 100% from the website. So doctors who ask about retaking, it will not occur now. It will occur within a few months. Did you have my course before?
Yes.
This is Dr. Minna. You will have a
Yes.
special offer, of course. So it will not be the number of fees given to anybody. Any doctor who had my course before will have very good discount. Don't worry.
Okay, thank you.
Or you need the general number, but I will not give you general number. You will have a discount.
Okay, thank you, doctor.
Okay, thank you.
دكتور
Other question?
أسامة
Excuse me,
Yes.
doctor.
السلام عليكم.
Salam.
And hello.
Yes.
Dr. Sama, I want to ask that I am already registered and my account is made on your website. So you have sent this link on our WhatsApp group. So I will join through WhatsApp group or direct I go to your website.
Look, you will study through the website, inshallah. Okay. From the coming lecture. Okay. After finishing the lecture, you will find the data, inshallah, on the website. It will be your source and your place of study. Okay. In relation, who asks about fees?
Okay, doctor.
Thank you.
Okay, doctor. Thank
Fees
you.
covering all package, including the crash course, $1,200. For doctors who does not want the crash course, although I strongly recommend it, it will be $850. Payment, and same as for part 1 MRCOG, I gave them one of two offers. Number 1, you can take early bird discount by having 10% discount, or you can have an offer of payment on 2 installments, half now, half after 1 month. So this offer for all doctors present today, and early bird, it will be until 30th of January. So one of two offers, early bird 10% discount, or you can pay on 2 installments. So for example, 600 now, 600 after 1 month. This package covers the long course attendance and 6 months on the website, including the 2 weekly exams, including the question bank. It will be available for you for free. How much after 10 discount? Okay, so minus 120 or minus 85. So here 1 1080, and here, okay, it will be 765, right? Right. Okay. Okay. And I will send you these packages on Telegram, so you can think. It will be with you on Telegram, inshallah. I will send it to you. Okay. We can start now immediately to have an example for our scientific topics. Okay, so I have to say the PowerPoint. I will stop recording.
This conference will now be recorded.
دكتور أسامة السلام عليكم.
Walaikum salam. Please delete questions after finishing the
Can
topic.
I ask something, please?
After finishing the topic, please. Because this video will be published.
This conference will now be recorded.
Okay, our topic now, inshallah, will be about one of the top articles talking about endometriosis and irritable bowel syndrome. At first, we need to think why they combined these two disorders into one talk article. Is there any similarity? And if there is any similarity, how we can differentiate between them? The answer is yes. There are similarities between endometriosis and irritable bowel syndrome. And yes, sometimes it's a challenge to differentiate between these two problems. That's why this talk article is present. How we can differentiate and what are the similarities and how we can treat irritable bowel syndrome, because we have a ISHRI guideline about endometriosis, MICE guideline about endometriosis. So we need here to concentrate more about this problem, irritable bowel syndrome, because questions came before in the exam about irritable bowel syndrome and how to diagnose, what is Rome criteria, what is it composed of, how to treat. So let's start. Bismillah. At first, in relation to the incidence, we notice something. Endometriosis 10 to 20%. Irritable bowel syndrome 10 to 15. To which one is more common in females? Endometriosis more common than irritable bowel syndrome. Generally, we know irritable bowel syndrome can affect both. It can affect males and also can affect females, but it's more common in females. That's why it's the first similarity. Talking about a disease specific to females, another disease more common in females. Okay, when you talk about number 10 to 15%, according to colloquial, it will be very common. It's a very common, both of them, very common, but endometriosis more. And in irritable bowel syndrome, it tends to occur in families. Same with endometriosis. In endometriosis also there is genetic factor. So you will find a woman and her mother and her sister having same problem of endometriosis. So why endometriosis happens? At first, what is endometriosis? It's the presence of endometrial-like tissue, glands, and stroma inside the peritoneal cavity or generally outside endometrial cavity. Because endometrial cavity is the normal place to find endometrial tissue. How it can be present elsewhere? This is endometriosis. If present inside the myometrium, it's called adenomyosis. Outside uterus or on the serosa, it's now endometriosis. Why endometriosis happens? Actually, we don't know the exact cause so far. That's why it's a disease of theories. One of the very important theories, retrograde menstruation, Samson theory, that during menstruation, some endometrial-like tissue goes retrograde to be implanted into the peritoneal cavity. Normally, these cells and this endometrial-like tissue will be killed by inflammatory cells, by macrophage. So no endometriosis is going to happen. So what happens? In some women, the macrophage don't perform this function, so they allow growth of this endometrial-like tissue. So retrograde menstruation and the immune system does not react. It's one of the theories. Another one, blood spread. Through blood or through lymphatics, the endometrial-like cells will be implanted elsewhere in the pelvis. To have the body to allow this to happen, it means that the immune system didn't take an action. So there is element of immune dysfunction. Because Samson or retrograde menstruation occurs in many women, but not every woman will develop endometriosis. So the immune system is involved in the pathophysiology of endometriosis. So what about irritable bowel syndrome? Irritable bowel syndrome includes a group of symptoms which have specific criteria, like change in the frequency of defecation, like constipation or diarrhea, change in the consistency, like more solid or less solid stool, and these manifestations of abdominal pain and bowel symptoms, characteristic point, they improve with defecation. Again, they improve with defecation. So a person having pain, irritable bowel, with defecation, there is some improvement. So why irritable bowel syndrome happens? They believe that in most of cases there was infection before. This infection led to imbalance between the normal intestinal flora and the pathogenic bacteria. Up to 30% of patients with gastroenteritis, they develop IBS. So the commonest theory now for irritable bowel that it's post-infectious. Important point, post-infectious. So infection leading to disturbance in the bacteria, which will be more than the gut flora, so it will persist as irritable bowel syndrome. That's why one of the methods of treatment said, okay, let's improve the gut flora. How? By giving probiotics, medications containing intestinal flora. So it will increase again intestinal flora. You know the problem of bacterial vaginosis? What is bacterial vaginosis? Bacterial vaginosis is not infection. It's imbalance between lactobacilli and the pathogenic bacteria. So pathogenic bacteria will be more than lactobacilli. So bacterial vaginosis happens. It's not infection, it's imbalance. Here also there is imbalance, but mostly happening after infection. So one of the theories to give probiotics. Are there similarities between IBS and endometriosis? Yes. Both of them can give cyclic symptoms. We know that the pain with endometriosis always occurring premenstrual and during menstruation. It's combination of congestive and spasmodic dysmenorrhea. Okay, so it's cyclic. It occurs some days every month. Also, IBS can be cyclic. Oh my God. So there is similarity, yes. Why? Why there is cyclic nature in irritable bowel? Because sex hormones can play a role. So it will fluctuate with the fluctuation of sex hormones in the body of the females. This may explain why IBS more in females, related to hormones. Also, psychological factors. Also, having some types of food, like some types of carbohydrates, they can aggravate the problem. Dr. Osama, we noted something. Some women with endometriosis, okay, she has severe symptoms, but we do laparoscopy, we find minimal endometriotic spots. What do you mean, doctor? I mean there is discrepancy between the pathology and the symptoms. So having by laparoscopy mild endometriosis, but manifestations severe. Why there is discrepancy? Why there is poor correlation between the finding and symptoms? Because there are associations. What do you mean? Patients with endometriosis, their pain is not only caused by endometriosis. Why? They are at risk more than other women to have fibromyalgia, chronic fatigue syndrome. Okay, it's more to happen in these patients. So it's not only a matter of treating her endometriosis. No. Also, there are associations by having other problems. I can treat endometriosis, okay, but when I will give her treatment, she will not have complete recovery. Why? There are other elements. So I can refer her for other specialties to treat the chronic fatigue syndrome or to treat fibromyalgia. Rheumatologists can treat fibromyalgia well. Okay. So what are the symptoms? This question came before in the exam. How you can diagnose IBS, Irritable Bowel Syndrome, using Rome 3 criteria. Rome 3 criteria. Sometimes they write Roma 3. So Rome 3 or Roma 3, okay, no problem. They are the same. Because in the CBD questions of the talk article, they wrote Roma. Okay, so Roma or Rome, no problem. What is Rome 3 criteria? There are bowel symptoms. Like what? Like straining with defecation, urgency, feeling rapid desire to evacuate, feeling of incomplete evacuation. Okay, and these combination of symptoms, they happen at least 3 days per month, and the patient suffered from them at least in the last 3 months. So I will ask my patient, did you have these symptoms? Yes. Did they happen in January? Yes, doctor. More than 3 days in January I had these symptoms. Okay, what about December? Same. What about November? Same, doctor. You have all symptoms with the coming criteria, at least in the last 3 months, at least 3 days per month, and they are 3 characters. What are the characters? When I have these symptoms, doctor, I go to the toilet, I evacuate, I feel improvement. And during these months, doctor, I feel I go to the toilet more or I go less with constipation. And even the consistency or the form of stool, it's more fluid or more solid. Both sides can happen. More solid, more fluid. More frequent, less frequent, and improves with defecation. Yes, doctor, you are right. Already, more than 3 days per month. In more than the last 3 months, I had these symptoms. Ask your patient. When the first time you had such symptoms? If she told you more than 6 months, it's a clear diagnosis of IBS. IBS diagnosis is clinical. Nobody will ask for investigations to diagnose IBS. You can ask for investigations to exclude other problems like inflammatory bowel, malignancy, any other problem in the bowel. Okay, and as we said, don't forget associations, fibromyalgia, chronic fatigue, so manifestations will not have same severity of the histopathological finding. Again, Rome 3 criteria. Manifestations at least 3 days per month, and they should happen in the last 3 days, in the last 3 months. And there are 3 criteria. I am not forward, okay? It's 3 criteria happening at least 3 days per month, at least happened in the last 3 months, and the onset at least 6 months or more. They are Rome 3 criteria. So 3 days, 3 months, and 3 criteria, at least 6 months. Okay. Clinical manifestations of IBS. They classify it according to what is the most important symptom in this patient. It can be constipation predominant, so my treatment will be mainly targeted to laxative, stool softener, or diarrhea predominant, so my treatment mainly will be by decreasing the peristalsis, or anti-diarrheal medications like lobramide, which is an opioid. It can be mixed, both of them present with same percentage, or unspecified. We cannot specify. So we have to classify the patient according to what is the most important symptom. Okay. Still not clear how we can differentiate between IBS and endometriosis. In IBS, manifestations mainly bowel. In endometriosis, there can be bowel symptoms, but also you will find dyspareunia, you will find dysmenorrhea, menorrhagia, heavy menstrual bleeding. So if manifestations mainly bowel, it's IBS, bowel and genital endometriosis. Okay, what else similar between IBS and endometriosis? Something very interesting. You know, when you examine a patient with endometriosis, you will find the pain, tenderness. Same will happen in IBS. In IBS, if you touch the bowel, okay, like while doing BR, it's painful. Painful more than it deserves. It's called visceral hypersensitivity. What is the meaning of visceral hypersensitivity? Tissues are tender. Tissues are tender, hypersensitive. Even if the stimulation is not very painful, the response is very exaggerated. Tissue hypersensitivity. That's why you will find in the treatment GABA to decrease nervous response. And you will find antidepressants to decrease activity of the nerves. Why? To correct visceral hypersensitivity, which is present in both endometriosis and also in IBS. Okay, how to investigate? In IBS, it's a clinical diagnosis using Rome 3 criteria. Lab or imaging can be done to exclude other causes, but it's diagnosed clinically. Endometriosis, ultrasound is very good. By ultrasound, you can find endometrioma, you can find endometriotic spots, okay? You can find uterus deviated, you can find fixed RBF by adhesions, for example. Okay. Ultrasound is very good, but it's only diagnostic. While the diagnostic and therapeutic one in endometriosis, laparoscopy. Because when you do laparoscopy, you find endometrioma, cystectomy, laparoscopic cystectomy. When you find endometriotic spots, excision. Take care. Excision, not coagulation, not vulgaration, excision. And in the cystectomy, don't say deroofing, don't say aspiration, excision. Anything you will excise will be sent for histopathology. Okay. MRI also can show you hidden or subtle endometriosis or deep infiltrating endometriosis. You can do transvaginal ultrasound or transrectal ultrasound. Okay, here in this picture you can see what is rectovaginal septum endometriosis. Rectovaginal septum endometriosis. Okay. What if I suspect clinically endometriosis? Can I find the laparoscopy negative? Yes, it happens in 1/3 of patients. Important exam question. In what percentage of patients you will find negative endometriosis while she was diagnosed as endometriosis? In 1/3 of patients. In 1/3 of patients. Okay. And also, when you investigate a case of chronic pelvic pain, 1/3 of them will be endometriosis. So take care. General prevalence of endometriosis, 10 to 20%. What if you are talking about patients of chronic pelvic pain? 1/3 of them endometriosis. Okay, by taking a biopsy, you can investigate for some markers. You can increase the diagnostic accuracy of laparoscopy. That's why excision and histopathology. How to treat endometriosis? What is the problem? There is pain. This is the main problem. The problem also can be subfertility. If the problem is pain, we can give analgesics like non-steroidals. Okay, we can give contraception. Why? Because with monthly endometrial shedding, bleeding happens in the endometriotic spots. Blood is irritant. It will induce inflammation. So pain, inflammation, adhesions. That's why we can suppress or prevent ovulation and menstruation. How? By using combined. If you give combined, better to give it continuous. Why? To avoid the monthly shedding. GnRH analog. If you give it more than 3 to 6 months, take care, she can develop menopause symptoms. You will need to give HRT. Progesterones like Mirena, it will release some progesterone inside the pelvis. It will improve symptoms. Or aromatase inhibitors like letrozole. Okay. If you are going to do surgery, no need for hormonal treatment before surgery. And when you do the surgery, remove, excise any endometriotic spots and excise endometriomas. Okay. Final decision, final last step to do surgery. But to be frank, surgery here does not guarantee 100% improvement. Why? There can be hidden endometriosis. Okay. In IPS, treatment according to what is the commonest symptom plus general treatment. General treatment like what? Avoid some types of fibers. So, dietitian will be involved. Beans, fatty foods, caffeine, chocolate, sugar substitutes, alcohol. Reducing them will improve IPS. Moderate exercise, because there is psychological element. Exercise will improve psychological element. Okay. If the problem diarrhea predominant, you can give antispasmodic to decrease peristalsis. Decrease peristalsis. There is psychological element, as we said, so you can give antidepressants or SSRI. But take care, TSA, they can have anticholinergic effect. They can induce constipation, so suitable in patients who are diarrhea predominant because it can induce constipation. So good for diarrhea predominant patients. What else can be used? In patient with constipation predominant, you can give laxative, and alhamdulillah, there is good evidence about some antidiarrheal that they can be used for long term without long term problems, like macrogel, sina, bisacodyl, and lopramide. Lopramide is an opioid. It's used to treat diarrhea. Probiotics. What is the principle? There is imbalance between the flora and the bacteria. So we can increase the flora by giving probiotics. Okay. There is psychological element. We can give SSRI, selective serotonin reuptake inhibitors. Ondansetron, it's an emetic, but it has an evidence that it can decrease diarrhea. So can be used for diarrhea predominant. Cognitive behavioral therapy, that we can sit with the patient. What is the problem? Do you have any problems? Any problems at home? Any problems at work? Okay, and they try to talk and discuss with her. She can be psychologically relieved. This is cognitive behavioral therapy. Cognitive behavioral therapy is the first line in all mild psychological problems. Pre-GABA. Why? To reduce neuropathic stimulation. We said there is visceral hypersensitivity. We can give GABA to sedate these nerves, to reduce the impulse from these nerves. Okay, clear so far? Anybody has a question so far? Clear? So we have two problems, endometriosis and IBS. Some similarities, cyclic symptoms, and hormone dependent, and visceral hypersensitivity. We have differences. IBS, mainly bowel symptoms, while endometriosis, bowel and genital. Diagnosis, IBS clinical using Rome 3 criteria and exclude other causes, while in endometriosis, clinical examination, history, ultrasound, laparoscopy in some cases. Treatment in endometriosis, prevent ovulation or analgesics. In IBS, according to more diarrhea, so antispasmodics or lobramide. More diarrhea, so antispasmodics. If more constipation, you can give these laxative, which have long-term no side effects in the long term. Okay, we can solve these few questions, then I will receive your questions, inshallah. With regard to epidemiology of chronic pelvic pain, more women present with endometriosis than IBS. What do you think? Which one is more common, endometriosis or IBS in females? Which one more common?
Endometriosis.
Endometriosis, you are right. We said 10 to 20% in endometriosis and the 10 to 15% IBS. So the answer is true. Endometriosis more than irritable bowel. Okay. IBS is more common in male, same like female. What do you think?
False.
Same?
No,
False.
female
So
more.
what is the right?
False.
Female.
Female common. Female more common.
That's false.
Yes, I have a theory. I don't know if you accept it or not. Doctors more common. What do you think?
Right.
Gynecologists
Yes.
more common. Stress, psychological factor. Okay. It tends to occur in families.
True.
IBS.
True.
Yes, we said yes.
True.
Both of them can occur in families. Endometriosis has familiar tendency. Yes.
Yes.
We said there is genetic
Yes.
factor, and this is the explanation. There is genetic factor. You can find families with endometriosis, families with IBS. Okay. In Roma 3 criteria, diagnosis will include pain, discomfort, at least 3 days per week in the last 3 months.
False.
So
False.
what is
3
right?
days. 3
Per
days
month.
in a month.
3 days per month in the last 3 months, and there are 3 criteria. The onset should be at least since 6 months. So it's false. The correction, 3 days per month. Okay. Pain should improve with defecation according to Rome criteria. What do you think?
True.
True.
Yes.
That's
True.
right.
True.
Manifestations should improve with defecation. It's in the Rome 3 criteria. Okay. Onset is not necessarily associated with change of frequency.
False.
It's involved. It must be present. It's one in the Rome criteria. With respect to IBS and endometriosis, non-colonic symptoms are more in IBS than endometriosis. Non-colonic, colon.
False.
False. Non-colonic
It's common.
will be
It's common in endometriosis.
non-colonic are more in IBS. No, non-colonic will be more in IBS. So it's false.
True.
How true? Non-colonic symptoms are more common in IBS. No.
Non-colonic means gynecological. That's common in endometriosis.
Yes, more common endometriosis. So
it's false.
it's false.
Yes.
Because colonic symptoms more in IBS. So non-colonic, these mics, colonic symptoms more in IBS. So it's a false. Okay. We finished this talk article about endometriosis and IBS. Okay,
Doctor.
I will thank all of you. I will stop recording, then I will start receiving your questions. At first, thank you everybody who attended our lecture today or watched this lecture on YouTube. Thank you. Assalamu alaikum. Have a nice day.